Thank you, Dr. Khanna. It's a pleasure to stay here to present our work on this field. First off, I would like to make clear that we as a company, and I'm a researcher in a company, we are working to make the complex structural heart disease treatment safe and simple. And I think that this is part of all that we all are working, and it's a long history, not my history, but a history, and I consider this a history of the humankind to treat more and safely the patients. I'm not engineer, I'm a physicist. My background is physics, and I've always liked to see the history of the science and technology. And I think that it's important for us back to see how the pioneers they worked and how they build everything that we have now, and how we can improve this and move forward and prepare for the others to make the achievements that we want to see in the world. I consider that, as you can see, I'm a physicist by heart. Then it's something that I'm always quoting this. I consider that we need always to think how we want to change the world and how we will change what we are doing. And we need to learn the things, we need to apply our knowledge, but we need always think and imagine how we will move forward. And in the history of the percutaneous valve therapy, in the recent last 30 years, we saw a huge improvement. This history, it's a long history, is more than 100 years of history of the doctors trying to solve the valve problem, the valve disease, the structural heart disease. But in the last 30 years, we saw a huge advance with some works of these pioneers thinking about the percutaneous valve treatment, applying the stent tech to treat the structural heart disease, looking to replace the valves, to repair the valves by the percutaneous treatment. We saw in this some few images from Dr. Anderson, Dr. Cribier, and Dr. Figula, previous work in the beginning and late of the 90s. Then this is the starting point of everything that we are seeing now. And in the last years, we saw and we are living with a lot of new words. We are all the time seeing and listening and talking about TAVR, about TMVR, TPVR, this new transcatheter valve replacement. We are applying this to the aortic valve, to the mitral valve, pulmonary valve, now to the tricuspid valve, and it's an evolving scenario. We are all emerged by this new technology all the time, and this we are pushing forward this to have better outcome, to have better technology, safer technology, and make this reproducible by everyone around the world. And when we think about this last 30 years, we huge change in the technology and the knowledge that we are producing and we are sharing. We can see here 30 years ago, the first paper was not accepted. The first paper for transcatheter valve treatment was not accepted by the JAC, by the circulation. And now 30 years after, we have more than 10,000 papers published about this topic. And we see that per year we have more than close to 2,000 new papers with more knowledge, more information, more technology. Then we see the huge increment in this kind of field. The same as for TAVI, for the aortic valve, we have for mitral valve and tricuspid valve, pulmonary valve. Then it's something that has changed a lot in the last 30 years. And when we talk about changing, we can see And here I'm proud to say that I was there since the beginning. We can see how the technology evolved, how the device evolved, how we move from a concept, a very, in the beginning, very rustic, not refined concept. Then we of efforts, a lot of testing, and we review the concepts, we update the things until the final design to use this. But this is not only for the valves. For the valves, we tried a lot of design. We put our imagination to move, and we applied the knowledge, and we saw and we tried different concepts, different ideas to move forward, to find a way to put this in the final use. But we can see the same in the other technological fields. Here we can see the part of the history of the planes. If we saw the plane in the beginning of the last century, and then 20 years after we have something more robust, and the things is spreading around the world, and 30 years after that initial beginning, we spread everything around the world. And we can bring this the same to the valves, to the cardiology, and the other medicine areas, where in not so big lab space have huge improvement of the technology. And this, we move not only by the valves, but we see this technological evolution in the other areas like the imaging. Imaging is something that it's helping and pushing forward, and working together with the device development, with the material development. It's helping us to understand better the disease and understand better the effect of the treatment and the behavior of the implants that we do, and the evolution of all of this. More than this, more than imaging, we have a new, and maybe without any previous parallel in the computational power, then we can improve the acquisition of imaging, the techniques of imaging. We can apply a lot of computational work on this. Then we can see in details what is happening inside the body. And more than this, we can predict what will happen when we use a device, when we plan to implant a device. We can simulate the behavior of the device. We can predict the result after implantation of a new device. Then we can prepare and we can produce everything in a silica way to predict the results. Then we are living in a time where we can, with our imagination, with our knowledge, we can predict everything that we will have. Then it's an amazing time to develop these new devices. And how we move. We start with unmet clinical needs, then we think and we move for new technology, and then this new technology will change the paradigm. But in this cycle that we will always have this new technology creating new unmet clinical needs. And we can see this in the history of this percutaneous valve treatment. When we start with this, we need to create a heart team. We need to put the surgeon with the cardiologist working together. We need to change the place where they are doing the intervention. It's not more a cath lab, it's not a surgical room, it's a hybrid surgical room. We need to move with new medicines for anticoagulant and new therapies for the patient. For problems with this technology, then we look for embolization protection devices with large introducer, with system for closure of the access. We saw the need for new imaging techniques. Then we start to use with image fusion. Then additional techniques was needed for some special case, like the basilica technique, where we need to cut the leaflet of the valve, the previous aortic valve, or lampoon when you do cutting the leaflet of mitral valve for mitral intervention. We start to see valve-in-valve procedures, and then we start again. We have new unmet clinical needs. We will need new technology, and then we will again change the paradigm, and we will have this cycle. And I hope that not a finished cycle. We will keep running this for a long time, improving the quality of the treatment that we offer to the patient. And for new technologies, we have a cycle of adoption of new technology, that it's something that we know this from other technology. We start working with innovators, then just a few amount of the possible user do this new technology. We work together with the company, we'll help to develop this new technology, and then we will have the adoption for a large amount of user, and then until the moment that most of the user will be using the new technology. And this is something that we can see for mobile phones, for new cars, and for the medical device. This is how the technology it's adopted by the users. And how we do this. Here I will present you some new devices for this new paradigm that we are changing, like the mitral valve. We are developing a transcatheter mitral valve, and this is something that it's not something that just appear like this. We apply a lot of work to have this. We start with some concepts which we try to adapt some previous technology, then we move for the concepts evaluation to check the feasibility of this concept, and then to move to a final design to start to apply this. Then it's again, it's another cycle when we start to think how to use the previous knowledge to move this, to adapt this, and reach the final design of the parts. The same we can apply to the aortic valve that we are developing, different kind, self-expandable, balloon expandable. For the percutaneous valve treatment today, we have different options. We have different options for the material, bovine pericardium, porcine pericardium. Soon we will start to see the polymeric valves emerging in the market. Here, example of a pulmonary valve, another valve, then we are reaching all the valves. And then the new technology that we are combining different fields of technology, the aortic valves, plus the brain-shed stent grafts and the coronary grafts, all together to have a new kind of treatment. This is an example of device for percutaneous dental debonus surgery by totally transcatheter implantable device. That it's something that we are pushing to have this option to treat very complex disease. And all of this that we are doing, it's based on a new concept for the biological tissue used in, it's a dry tissue. It's something that we see as a next movement for the valves, the biological valves, because with this kind of treatment, we can increase the mechanical characteristics of the material. We can, after we dry the tissue, we can return to the wet condition, improving the characteristics of the material, increasing the stability of the material, making this more resistant to thermal variation, that it's a problem for the biological tissue. At the same time, we are preserving the biological components, keeping all the collagen structure in place without any kind of rupture and no damage, and improving with the anti-calcification technology. We are removing the glutaraldehyde, we are decreasing the risks of any biological problem with the tissue, at the same time that we can prolong the lifetime of this, avoiding the calcification, degeneration of the tissue. All of this with a lot of work, a lot of testing, a lot of bench work, lab work before we move further to the application to make easier to use. Then now we have a valve that it's just operation of flush to have the valve ready to implantation. Just open the package, just flush the device, then it's ready to use. And this is something that it's already in use. We are using this technology in the treat valve. And here it's another example of how we can move further with the new ideas, changing the paradigm to the treatment of the disease. This is a treat valve. It's a device to treatment of tricuspid regurgitation. And we are doing a heterotopic implantation of the valve. We are putting the valve outside the heart. We are avoiding all the challenges to implant a valve in the native tricuspid position. And with this logis, we move the cardiac intervention to a vascular intervention, a venous vascular intervention, and we will treat the valve disease. We see in our trials the improvement of the quality of life of the patients after treatment. We improve the score, the quality of life scores for these patients, the functional class of the patients. Here we can see after 1 year, more than 85% of the patients, they are in class 1 and 2 after 1 year of the treatment. And in the screening, all the patients were class 3 and 4. Then we can see this, the improvement of the patient. We can see a high survival rate in those patients. And we expect that it's something that we saw in the literacy, that this patient with severe tricuspid disease, they have a high mortality. And after the treat valve treatment, we can expect a low mortality rate similar to the patients with non or mild tricuspid regurgitation. Then this is how we are moving forward. We are applying this knowledge that we have. We are thinking about the new treatments, the new way to move forward, and always based on the previous knowledge and the work of the pioneers. And we are always moving this, looking to have a safer procedure, and more reproductively, and solving issue that until now we cannot treat. Thank you.
Thank you very much, Dr. Agrelli. That was indeed very great and innovative, and it's very exciting and to actually work with the mindset of a physicist or an engineer. When I was getting trained under Michel, I used to work with Nuruddin, who was from Cardiatis and who invented the multi-flow mediator, and also the Corvita valve. So I used to understand his way of thinking, and he used to understand the physician's way of thinking. And it used to be very good and to, actually churn our ideas and get into something new and exciting. So thank you so much for this oration. As we know that the oration does not carry, it's not followed by any questions. We'll have the questions in the end or privately on the chat box. I would try to, this is the plaque. This is a virtual plaque which we would be handing over to Mr. Subramaniam to be delivered to you in real. And this is the plaque for, which says this is a M.N. Khanna Oration Award 2021, which is being conferred to Dr. Agrelli from Brazil for his pioneering work in changing landscape of percutaneous valve therapy on this day, 19 December 2021. We wish you a very long life and many years of productive life. So we present this virtually to you on behalf of the Asia Pacific Vascular Society, and the original plaque we are going to hand over to Mr. Subramaniam, who is going to be handing it over to you.
Thank you. Thank you. It's a pleasure to present this